Welcome to our third and final webinar of the Taking Care of Diabetes Together series. This is our monitoring and motivation session to finish off the time. I'm Caitlin Mellendorf. I am a nutrition and wellness educator with Illinois Extension in the central part of the state. I will be moderating today's session. And our presenters today are Rachel Mannon. She's a University of Illinois Extension educator as well, and registered dietitian located in the heart of university, serving Champaign, Ford, Iroquois, and Vermilion counties, and focuses on teaching classes around chronic disease, food safety, food preservation, and in her free time, she enjoys spending time with her family on the lake. And we have a special guest presenter today who's going to be joining us. This is Jenny Kerwin. She is also a registered dietitian and a certified diabetes educator, certified diabetes care and education specialist. She has worked at St. Mary's Hospital in Decatur between 1998 up until 2016. Then the Joslin Diabetes Center affiliate of HSHS between 2016 and 2020, and is currently at the SIU Family of Medicine in Decatur. And they will both be presenting our session today. So as we've talked about in previous sessions, University of Illinois Extension is an outreach of the university at Urbana-Champaign, and our goal is to offer evidence-based educational programming to the public, and we cover all 102 counties within the state on topics around food and agriculture and youth programming and much more beyond that. And so if you've not visited us on our website, you can visit that at extension.illinois.edu, or you can find your local county. And so to kick us off, Jenny is going to continue the session for this afternoon.
As I was saying, I don't have any disclosures, and today's topic is going to be on continuous glucose monitoring. I'm talking about some of the devices out there that we can use with our clients and some of the benefits with using a continuous glucose monitor. So who can benefit from continuous glucose monitoring? Obviously, anybody who is not in well glycemic control, any individual that has type 1 or type 2 diabetes that's on insulin, individuals that need to have their insulin therapy optimized for better control. And we all know that doing finger sticks is a chore. It's inconvenient. It can be very sore for people to have to do multiple sticks every day. So it's definitely a convenience for a lot of our clients. Anybody on the insulin pump is going to want to be using a continuous glucose monitor. And then if you have frequent low blood sugars or high blood sugars, this is a great way to kind of target those areas. It's also a safety mechanism to have that CGM, so we get alerted for those lows and highs before it gets to the point of being severe. Hypoglycemia unawareness, we do have occasional individuals that have no warning signs for that low, so that CGM will notify them if their blood sugar is starting to drop before they even get to that 70 mark. So again, it's definitely a safety thing, gives peace of mind for people, especially during the nighttime when they're sleeping. And then if you have anybody that's maybe elderly or young kids that maybe need to share their data with parents or loved ones, this is a great way to share that data so the parents, the loved one is notified if that individual is having lows or is having high blood sugars. So it's good to share with your family and friends. Next slide. So benefits of CGM, obviously, the goal is to optimize diabetes management and control. We're going to reduce that risk of hypoglycemia and hyperglycemia. It also allows these individuals to be proactive in their care and allows them to respond to glucose trends immediately so they can kind of see how different things affect their blood sugar, such as food, activity, medications. It allows improvement in time and range, and that's something that we look at when we look at these reports. Our goal is to have time and range greater than 70% in a 24-hour period. So it allows us to target maybe certain times of the day that they're not meeting their target goals. And then also nighttime blood sugar control. Most people aren't checking 4 or 5 times during the night. So this CGM allows us to see what's going on because it's monitoring their blood sugar every minute to every 5 minutes, depending on the system that you're using. So it really gives us some good data on how to manage issues with nighttime blood sugars. And then all this data that we're collecting on these reports are put into a very readable format for the healthcare provider and also for the individual using the CGM to help make decisions on what would be the best management treatment. Next slide. So there are a couple options, and the ones that I'm going to just kind of focus on today is I'm going to just focus on the Dexcom brand and Libre. That's kind of what we typically use in our clinic right now, but there are other ones out there, and there's many more coming on the market. So Dexcom G6 and Dexcom G7 are two of the ones that we typically use. The most current one is the G7. The difference between the two mainly is that the G6 has a separate transmitter that you have to replace every 3 months. So that's kind of been eliminated with the Dexcom G7. It does come with an applicator. It has a sensor and a transmitter that's all in one piece on the G7. It is placed on the back of the arm, and it can be used with an app on your phone, or it can be used with a receiver or controller. So if those that don't have the adequate phone, we can use a controller. And what's nice with this system, you can use both the controller and the Dexcom app at the same time, which is really kind of a nice option. So if you're starting somebody on Dexcom, most people are now going to be starting on the Dexcom G7 versus the G6, but we still have a few people on the G6 that are with insulin pumps. The Dexcom Clarity is actually an app and also a web site where you can go to look up your reports. We use that to pull up our reports when we're sharing data with our clients. And then you do have the Dexcom G7, G6 apps on the phone. And then also Dexcom Follow, that's the app that you're going to be using if you want to share your data. So the person with the CGM will allow sharing of data to their loved one, and they can see and get those alerts and alarms. Libre 2 now has just advanced to Libre 2 Plus and Libre 3 Plus. So just the Libre 2, Libre 3 are now going to be out. So if you're ordering it, you want to do the Libre 2 Plus, most likely you're going to be using Libre 3 Plus. That's the most advanced. Again, the Libre Link Up app, that will be the app that you're going to use to share that data with your loved ones. And then they do have two separate apps. There's an app for Libre 2 Plus and there's an app for Libre 3, and they cannot be interchanged. So you have to use one or the other. The difference that I really found mainly with the Libre 2 is that you have to scan your sensor every 8 hours to get all that data. So what I saw a lot of times is people forget to scan, or they go to bed at 10 o'clock at night. They don't wake up till 10. We're going to lose 4 hours of data. So we see a lot of gaps in the reports. That's kind of been eliminated with the Libre 3. So you don't have to scan. It holds much more data. So you don't have to scan that sensor and put that information into that reader. So that's the biggest difference. So normally, if you're going to use Dexcom or Libre 3, you're going to do the 3 Plus and the G7 as most likely the most up-to-date sensors. Next slide. So just to kind of compare some of that, they all have alerts and alarms. So they're giving you readings on the Libre every minute, and then the Dexcom is going to give you readings every 5 minutes. They all use apps, so if you don't want to carry a separate receiver, you can definitely just use the app on your phone, which a lot of people do prefer, so they have to carry two devices. As for size, the Libre 2 is a little bit bigger. It's about the size of 2 quarters that are stacked, where the 3 Plus is more like 2 pennies stacked. So it's a much smaller sensor than the original Libre 2. And Dexcom, similar to Libre 3, just a little bit thicker on the sense. So they're pretty small. Most people kind of forget that it's even on the back of their arm. So it's a great way to check your blood sugars without having to pull up your meter and do a finger prick and all that. So lifespan is 15 days for the Libres, and then there's a 10-day for the Dexcom, and it does give you a 12-hour grace period, so that if you can't switch it out right away, you do have a 12 hours before it will stop working. And then, of course, we talked about the memory. The memory on that transmitter is 8 hours for the 2 Plus, and now it's 15 for 3 Plus, and then 24 hours for the Dexcom. So you don't have to do that scanning originally that you had to do with the Libre 2. Bluetooth range, it is improved with the 3 Plus and the Dexcom G7 to 33 feet, which is nice. They're all approved for children 2 years and older. And the warm-up time was also decreased too, which is a good thing. So Libre is at 1 hour. So you insert the sensor. They do have a 1 hour warm-up time before they'll start getting readings. And then Dexcom has 30-minute, Dexcom G7, a 30-minute warm-up time. So they're not waiting long periods before they start getting readings, which is really great. As for calibration, there's no calibrations required with either of these brands. Libre 2 and 3 are calibrated in the factory, so you have no option to calibrate. Dexcom, though, does allow you to calibrate if you find you have a significant difference between a finger stick reading and a sensor and you think maybe it's not working correctly. They do have that option. You can do a finger stick. You can enter that data into your app and it will recalibrate the Dexcom. So that is an option for the Dexcom users. Next slide, please. In addition to other, we don't use these in our clinic, but Guardian 4 and the Simplera sync sensors, those are the ones from Medtronic that you're going to be using with the MiniMed pump, the 780G. And the one on the left, which is the Guardian 4, it looks like a seashell. That one you had to charge. It has a little bit more taping, a little bit more cumbersome to insert. Not bad, but it's just not as easy. Where the one on the right, the picture shows you just an applicator. You just press it and it inserts that little sensor underneath the skin and it has a transmitter already connected. So it's very easy to use. There's not a lot of setup. Anybody can, pretty much insert those. What's really nice though, they just came out with, not too long ago, a over-the-counter CGM. So Dexcom came out with Stello, and then Libre, Abbott came out with Lingo. So those you can now get over the counter at the pharmacy. You do not need a prescription for those. Where Dexcom G7, G6, Libre 3, 2 Plus, you do need a prescription for those. The difference on those over-the-counter CGMs is that they don't have the alerts and alarms. So if you have somebody on insulin or having lows, you're going to want those alarms. You're going to need the ones with the prescription on that. So, but typically, they're pretty similar to the Libre 3 Plus and also the Dexcom G7. They just don't have the alerts and alarms that most people probably want to have if they're on medication or insulin. Medicare, usually not covered by Medicare. As for private insurance, that's really going to depend individually on what type of insurance that you have. Next slide. And then this is Eversense 365. In our clinic, we do not use this. It's actually an implantable sensor that goes in your arm for 365 days. So the little device is you see in the picture there is inserted by a physician underneath your arm. And then the black piece is your transmitter, and that's on the outside of your arm. The difference with this, it does require daily calibrations for the first 2 weeks, and then at least once weekly. So you do need to do finger sticks once in a while to keep that calibrated. And then there's also a little charging. That transmitter, you do have to charge that for like 10 to 15 minutes. Most people just do it when they're in the shower, get it charged for the day. So there's a little bit of charging on that. Warm-up time, it does take 24 hours before you're going to get those readings. It does work with a smartphone. It is only approved for people 18 years and older, and it is covered by Medicare. Right now, it's not compatible with an insulin pump, and there is training that's required. So the primary care provider is going to have to do some training on how to implant those devices, and the individual won't do that themselves. They have to go into the office to get that inserted. So some of the insulin pumps, though, are working with Eversense to get that automation insulin delivery connected. So you'll probably be seeing that in the near future, that some of these sensors will be connected with some of the insulin pumps out there. Next slide. So Medicare, just if you have patients that want to get a CGM, most of those individuals are going to have type 1 diabetes, type 2, or gestational diabetes. They will also need to be on insulin, unless the other criteria is if they have documented hypoglycemia, where they have level 2, which means their running blood sugar is less than 54, or they've had a level 3 hypoglycemic event where they needed third-party assistance. So if a doctor or healthcare provider documents that in the clinical record, we've gotten some people covered that were not on insulin, that were having severe hypoglycemic reactions, that we were able to get them covered. But again, that you must have that documented. So in your clinical notes, make sure that the doctor charts that they have diabetes, they are on insulin, that they have had training. It's a good idea just to do the training, make sure people know what they're getting into. So document that in the note. And then every 6 months, they will need an updated clinical note from Medicare that they're continuing to use it. So the doctor needs to put in that, yes, patient is still on the CGM to maintain their diabetes management. And every once in a while, I'll have a doctor forget that I have to call them and say, hey, I need an updated note. Medicare is not going to reorder or, make these, that requirement's not met. So we have to go back and adjust that note. So just keep that in mind. Next slide, please. So there is a difference. So this is a common issue that I see with a lot of my patients. They'll come in and say, I don't think my CGM's working. And they're checking their blood sugar still. And what they're seeing is a big difference between a continuous glucose monitor result and a blood sugar test. And that's okay. They're not going to always be the same. So if you look at this graph here, this is showing you, think of a train. If I have an engine and a caboose, the engine is my blood sugar reading in the red. My caboose is the continuous glucose monitor. If my tracks are flat, I'm not going uphill, they're going to be pretty close together. The numbers are going to be fairly close. But let's just say I just got done eating a big meal with a lot of carb. My blood sugar, which is going to be my finger stick, is going to be much higher than my sensor reading. And the reason being is that sensor is monitoring blood sugar in the interstitial fluid that's around the cells. So when you eat food, it goes into your bloodstream first, and then it goes into the interstitial fluid. So there's a lag time between the blood testing and the sensor testing, about 5 minutes, and sometimes even 15 minutes. So you just got to make sure that people are aware that if they're rapidly increasing or rapidly decreasing in blood sugars, there's going to be a bigger span between the two readings of a sensor and a blood sugar meter. Next slide. So there is the accuracy of these sensors. It's called the 20 rule. And let's look at the Dexcom G7. It says if it's above 70, there can be a 20% difference between a finger stick and a sensor reading. If it's below 70, you can have a 20 milligram difference. So remember I said with Dexcom, you can do a calibration. So if somebody has a wider variance between the two readings, they can calibrate their sensor and it will kind of readjust on that. So it's the 20 rule. So just again, making sure patients realize that a finger stick and a CGM are not going to be exactly the same. Also, it's a good idea to let people know the first 24 hours may not be as accurate. So if you're dosing insulin or medications based on a blood sugar reading off the sensor, you may want them to do a finger stick, okay? And then also, it's called pressure on the sensor is hypoglycemic pressure. It might be a false hypoglycemic alert. So sometimes if somebody's laying on the sensor that's on their arm, they may get an alert telling them their blood sugar is low. So I usually tell them, if you're not having symptoms, do a finger stick to confirm, because it might just be compression hypoglycemia, meaning that if you roll off the sensor, it will readjust and probably show a number that's not low. So sometimes that will happen. They'll get a false low on there. So that's something they need to be aware of. So on here, this is Dexcom's handout. It just shows you the difference. So if I had somebody with a blood sugar reading of 100, their sensor reading can be between 80 and 120. If their blood sugar is reading, say, 300, the sensor reading can be anywhere from 240 to 360. So again, people think, oh my gosh, it's 60 points difference. That's not working. No, it is working. Remember that lag time. So sometimes I'll pull this out and kind of explain to patients and even healthcare providers that this is okay. It is working. Next slide. When you do get your reading, so when patients look at their monitor, their app, they're going to get a number and they're going to get an arrow. So you have to have both. If you don't get the number, you don't get the arrow, you don't rely on the reading, okay? So most of the time it's color coded too. If it's red, it usually means that you're low. If it's orange or yellow, it usually means that your blood sugars are above the target range. And then usually if it's a gray color, usually means that your blood sugars are stable. So a good example I like to work with people is that, let's say they're going to bed and their blood sugar is 120, but they look and they see two arrows going down. That means that their blood sugar is dropping 90 milligrams probably in the next 30 minutes. So they're going to end up being low. So this is a good teaching moment to say, the sensors are monitoring trends of your blood sugar. So if your trend is that you're dropping rapidly, you need to make a decision to treat versus wait. Okay. So especially if you're going to be getting a car to drive, or maybe you're going to bed, you want to make sure what's the trend of your blood sugars going. Is it going up? Is it going down? The other thing is, let's say you're in the middle of Friday night, you're having pizza, and you check your blood sugar before you start eating, and about 10 minutes into the meal, you start checking, you're at 200. And then you check a little bit later, and now you're at 250 with 2 arrows going up. That's telling that individual, hey, stop eating carbohydrates. You're already really high and you haven't even met your max yet. So really great teaching tool for a lot of people to look at those trend arrows. Next slide. There is alarms, and one thing I do recommend is that usually factory settings, usually at 70 and at 250. But when I start somebody on a CGM, and let's say they're running 400 blood sugars, if I leave that high alert at 250, they're going to get so many alerts, they're going to get alert fatigue and frustrated, and then they're not going to want to wear it. So initially, a lot of times I may adjust that high alert to 300, 350, depending on what they're running, with ultimately a goal to drop that back down to the 250 range as we get them under better control. But that's something to think about when you're looking at these alarms and setting them up for them. A lot of these sensors will also have a rise and fall rate alarms. Usually I keep that off because that's just, they'll be getting alarms again all the time if there's somebody that's rapidly increasing or dropping. So it's just too many alarms for most people. We talked about sharing data with clinics. The two platforms are Libre View and Dexcom Clarity. Those are the websites that we use to download their data and put that data into the charts for the doctors to review. And then I already mentioned compression hypoglycemia, but again, that's something you do want to make sure your patients are aware that that can happen. Next slide. Where do you place the sensor? So Libre and Dexcom G7 are now approved for the back of the arm. Dexcom G6 was approved for the stomach. However, we do have people wear them on the stomach and the arm. I'm just letting you know that FDA has approved certain areas for certain sensors. When they do insert the sensor, make sure they use an alcohol wipe, make sure the skin's dry so they haven't just gotten out of the shower. If somebody has a very hairy arm, they may want to shave that area for better adhesion. Also, some people, if they sweat a lot, a little bit of antiperspirant can help keep that adhesive sticking a little bit longer. Every once in a while, if I have somebody that lost a lot of weight or had gastric bypass surgery, or somebody maybe elderly that has poor muscle tone, they may have a lot of loose skin in the back of the arm. Sometimes the sensors don't stick very well, so we may have to use additional adhesive or different over tapes to get that to stick, or move the site to either their stomach or a different part of the arm on there. And just again, remember the first 24 hours, you do want to maybe use a glucose meter. So I always tell people, just because you're using a sensor, it's always a good idea to have a backup meter just in case. Next slide. Approved tapes. So I typically use Skin Tack. It comes in a little adhesive wipe, and it's easy to carry. Usually you can put it on before you insert it, like in a donut area, leave the center free of the adhesive, extra adhesive, and then insert. And then sometimes I'll take that adhesive wipe and just go around that center for a little bit extra adhesive on there. But they have other things like Mastisol, Tegaderm IV, Skin Prep. So there are lots of things out there to help keep those sensors staying on for that 10-day or that 15-day wear. There are also a lot of over tapes that you can get. Dexcom actually comes with an over tape, which is really nice. It comes with every sensor that you get. Next slide. And then removal, sometimes you have some really elderly people with very fragile skin, and sometimes that adhesive is pretty sticky. So baby oil can help loosen that up, or we have Tack Away and Unisolve are two things that I've used. And you just take that and put it around that sensor to kind of lessen that glue. Makes it a little bit easier to take off the arm for some individuals. So that's something that's nice to have also. Next slide. With the Dexcom, there is indication for interfering substance, acetaminophen, more than 1 gram every 6 hours, because it can falsely affect the readings, falsely increase it, and the hydroxyurea also can increase that. Libre 2, it's more the vitamin C. no more than 500 milligrams, and Libre 3 Plus has just been increased to 1,000 vitamin C. But the main thing would be if somebody's taking like Emergen-C or Airborne, or some of these vitamin C supplements during the flu season, sometimes they can falsely increase blood sugar readings. So it's just something that they should be aware of. And that's usually when they set this up, the apps go right through that and have that information already there, so they can see that while they're setting up their sensor. Next slide. This is just a overview of one of the reports that you're going to see. Real quick on this, things that I look at on the top, it says percent time CGM is active. Obviously, you want that close to 100% for the most accurate report. You'll get the average glucose. You'll get the GMI, which is actually a correlation to the A1C. So that's kind of a nice way to look at it. And then glucose variability tells me if, if I have somebody running a lot of highs and a lot of lows, their A1C might look good, but they're not in good control. So that's something you want to think about too. It's not just the A1C we want to look at. We want to look at time and range and percentage of highs and lows. And if you look at the far right there, their target range, they're 47% in target range. Our goal is to have it 70%. So that might be something I'm going to work on. What I see is a big issue though, if you look at the lows, they're having 4% lows, 58 minutes, and 6% very low under the blood sugar 54, which is pretty significant. So right now, if I'm not going to do anything else, I'm going to focus on why are we having those lows. So this is a nice report, kind of gives that provider a way to figure out what we need to target and what we need to discuss in their meetings with the patient. Next slide. Physical activity. One thing that can affect.
I think this was my slide, Jenny.
Okay, yeah, I was like, that didn't seem like mine, but okay,
Yes.
so.
Nope, you're good. I think Caitlin had a couple questions to ask before we go ahead and continue, though.
Yeah, so in the chat, there was a question about, are the CGMs only for insulin dependent folks?
So I do have individuals that are on sulfonylureas and on other medications. The issue is Medicare requires that you be on insulin to cover it. But I do have people pay out of pocket to cover it. Now, some commercial insurance, depending on your insurance, may cover it for people with just type 2, not on insulin. And then that's why they came up with the over-the-counter sensors, where some people want to do just for wellness. They may not even have diabetes, but they're looking at just wellness. And they don't need the alerts and alarms because they're not on insulin and medication. So now they have the options to get some of these over-the-counter non-prescription sensors. If I'm somebody paying out of pocket, a lot of times I'll tell them, maybe wear it for 2 weeks, and then the next 2 weeks, just do finger sticks. So you kind of spread that out a little bit. We're talking maybe $75 to $80 a month. Like that's a ballpark figure, out of pocket cost. So sometimes that's pretty expensive for some people.
And then this was my own question. On your slides where you talked about hypoglycemia, you had the number as less than 54 milligrams per deciliter. I know 70 is often also shared as hypoglycemia. Can you talk about that difference?
Yeah, 70 is low, but when we're looking at the documentation, is if you're going to document the need for a low or sensor for low blood sugar, they have to have it documented that they're having a blood sugar less than 54, or they have to have a hypoglycemia where they had to have third-party assistant where they weren't able to bring it up with food because they weren't alert enough to eat or whatever. So that's mainly, but yes, true hypoglycemia is under 70. That's only for the documentation to trying to get a sensor approved for the diagnosis of hypoglycemia. So if somebody has diabetes and they're on sulfonylureas and they're having hypoglycemia, we've been able to get a sensor covered because they're not on insulin, where most of the time insurances, especially Medicare, you've got to be on insulin if you want it covered or have that documented low blood sugar of less than 54 or third-party assistance.
And I have a follow-up to that is, do you find that insurances are with the right documentation in place, are insurances generally covering those pretty consistently?
Yes, we're doing pretty good with good coverage on most people that need CGM. There are a lot of them though, especially Medicaid. They're going to say, "Hey, we need a prior auth." That's just an extra paperwork that we got to do. But if the doctor puts in diabetes, that they're having high fluctuations in blood sugars, they're on insulin, they have been complying with their regimen and see the doctor every 6 months. Put that additional information in there will help cover it. But yes, I think the ADA guide or the standards of care actually is for type 1, type 2. CGMs is the standard of care. So I think more and more insurances are going to eventually start covering this and make this hopefully standard care for everybody.
Awesome. So on that really positive note, Rachel, you're going to take over for the second half of our presentation.
Yeah, so I'm going to talk about a little bit about physical activity and then just kind of tying this all together. So physical activity, you may or may not be able to be physically active in your clients. There is the standard USDA recommendation of 150 minutes per week, which is about 30 minutes for 5 days a week. And this can be broken up with different cardiac physical activities or muscle strengthening. They recommend muscle strengthening at least 2 days a week. But the first step is just kind of understanding those physical activity guidelines. And then the second step is to evaluate where you currently are. So if you are doing nothing, how to improve by that with just little steps too. We don't want to just go straight for the whole thing and set ourselves up for failure. And then discuss the barriers to physical activity with just your personal individual movements and then also your access to physical activity. Especially in Illinois, it's great to go outside like today, but earlier this week it was really cold. So all of those things and your access to maybe a gym or a fitness center or something like that. And then discussing physical activity options with someone, what you have at home versus what you think you should go out and do something at like a gym or something like that. And then also you can research programs and resources in your area to help meet your physical activity goals. And then before doing any type of physical activity, especially if you are currently not doing any physical activity, make sure to talk with your physician before exercising. Physical activity does affect our blood sugar, so that's important to keep in mind, especially if you are on insulin. So here, when we are talking about our cardiac physical activity, we can break it up into moderate and vigorous. So some examples would just be of moderate would just be walking around, doing water aerobics, dancing, pushing a lawnmower. And then those more vigorous intense could be jogging or running, cycling, and wheelchair workouts. With our muscle strengthening activities, we want to try to target all major muscle groups. And there are different ways that you can achieve this. Seated or standing Tai Chi is a great way. There's lots of Tai Chi classes. There are professionals in Extension who teach Tai Chi classes. And then you can also look up YouTube videos to kind of that walks it through with you. Chair yoga is another great way, and the National Institute on Aging has an chair exercises for older adults resource guide. It's aimed towards older adults, but really anyone can do those chair exercises. You can also just do stretches and balancing exercises using resistance bands. You can always add those in later. And then another thing is, especially if you don't have access to a gym, or whether it's, location or just money or mixture of both, something you can do at home is just get creative with things you already have to do, like like pull-ups or like a weights. Instead of buying actual weights, you could use water bottles or cans of soup or anything like that you could easily grab and do those. And then when we are talking about our emotional wellness, diabetes is a big diagnosis. It changes people's lives, and it can be very stressful and overwhelming for the individual as well as the caretaker. So it's important to take care of yourself to prevent diabetes, burnout, and stress and anxiety and depression and all of that. We want, with our positive coping skills, you can do things like music and art. Make sure to do try to make some time for self-care, doing breathing and meditation exercises, anything that helps you relax. And then knowing that it's okay to ask for help, whether you're asking for help from a professional and going to therapy, or taking antidepressant medication, or if you just need help from another family member or friend, or you need a vent or something like that. Find your group of support, and really lean on them. There's a lot of diabetes support groups. Some of the extension educators throughout the state do diabetes support groups, as well as I've seen local hospitals do them. I've seen public health departments do them. So just finding those in your area, if that's something you're interested in, to just help talk to someone about their struggles and their successes, to have someone to kind of help lean on you. And then we want to create and use our support team, not only, personally, but also with our professional support team. We want to make sure we have our doctors and our endocrinologists, our dietitian, everyone on board to help communicate and manage and support the diabetes. And then a tool to help us manage our diabetes is by creating SMART goals. And this is an acronym we like to use a lot. So that stands for specific. So we want our goals to be specific: who, what, where, when, why, how. And then we want it to be measurable, so that we can easily measure the progress. We want it to be attainable. We want to make sure that it's realistic for us. If we set ourselves up for failure and we have goals that are not realistic and we don't meet them, then we tend to get down on ourselves, and we don't meet our goals, and it can be kind of hard to start back up. So it's okay to start small to meet your goals. And then we want to make sure it's relevant. We want to, focus on what we're trying to accomplish with what our goals. And then we want to make sure we have a time limit set to just kind of help us evaluate if the goal was met or not. It's okay if the time has lapsed, and to ask, okay, did I meet this, or did I not meet it, or did I somewhat meet it? Maybe you halfway met it. And you can ask, was it manageable for me? How did it make you feel? So make sure to take time and discuss and reevaluate and adjust your goals at the end of that time limit that you set. So an example of a SMART goal could be, if you are, again, this is if you're currently doing eating no vegetables, starting out small. I would like to eat 2 vegetables per week for the next 2 months. And then after 2 months, you evaluate and see if you ate 2 vegetables per week. Maybe write down the vegetables. Maybe you have different vegetables, so you can make note of which ones you liked and which ones you didn't like. And then you can increase it the next 2 months, and then maybe do 3 or 4 vegetables per week. So just starting small, just to help improve our overall wellness. And then with motivation, how to motivate yourselves and others to take care of yourself and your diabetes. Talking about rewards versus consequences. It's important to never use food as a reward. That can kind of instill bad relationships with food, bad eating habits. But instead offering other rewards as motivation, and then also talking about those consequences that Caitlin talked about at the first session we had a couple weeks ago. With, if we don't take care of our diabetes, we could get heart disease. We could lose a toe. We could go blind, and talking about all those different things, and what would it be like if you lost your foot? How would that make you feel? And kind of having those conversations on this is what could happen if we don't take care of ourselves. And then with meeting our rewards and your SMART goals, you could have like a sticker chart or something, whatever works best for that person. And then having a reward when you do meet those goals. So maybe it could be a new book, or a new coloring book, or maybe some alone time with a special friend or family member, where it's just one-on-one alone time with them. Or maybe they just want alone time period. Maybe they just want an hour alone in their room just to themselves or something. Everyone's going to have different things that are going to work as rewards and motivation. And then also ask the client and get the client involved. Ask them, what is it that you want to work on? Ask if you meet this goal, what would you like to do? What is one thing that you would like to buy or do in order to celebrate your accomplishments? And then the more successes that they get, they like the way it makes them feel, it makes them happy, and having those rewards just helps instill meeting those goals. And then now we will go ahead and take time for any questions that you may have for me or Jenny.
Thank you so much, Rachel and Jenny. I just want to remind folks that if you are a caregiver of someone with diabetes, please know that we are hoping this webinar was supportive for you to remind yourself that you are important as a caregiver, and also to take time for yourself, not just while you're helping your person with diabetes manage their condition, but also taking time for you, because it's not a solo job. It's definitely something that takes energy and patience and people and support. Thank you so much for joining us for our 3-part Taking Care of Diabetes Together series. We hope everyone enjoyed themselves and learned a lot of things, and we will see you in future trainings. Thanks so much, everybody.